at GDC forum. That was a very nice talk, Dr. Swapnil. Thank you for that talk, and hope our both the speakers, esteemed speaker rather I say, Dr. Prathamesh and Dr. Sharmila, will help our members and their patients for what we are. This program is also live on other medias where patients can also join. So this will be a fruitful startup of this year with by observing this day. So I again welcome you all the esteemed members of Indian Dental Association Nagpur branch, all the officials, office bearers of Indian Dental Association Nagpur branch, Dr. Prathamesh, Dr. Sharmila. I declare that this CDH activity is open. Thank you.
Thank you very much, sir. Now, I request our moderator of the event, Dr. Swapnil Agrawal, sir, Consultant Head and Neck Oncosurgeon, to kindly introduce our honorable guest speakers for today's event. Over to you, sir.
Thank you. Thank you. So it gives me immense pleasure to introduce my mentor, my guide, my guru, Dr. Prathamesh Pai, sir. He's professor in the Department of Head and Neck Surgical Oncology at Tata Memorial Hospital. He's teacher for the MCH program. He's a versatile surgeon. Sir has special interest in laryngeal and skull-based surgeries with focus on laser and minimal access surgeries. He is convener for the multidisciplinary skull-based clinic at TMH. He is a member of Institutional Review Board at Tata Memorial. He has over 60 peer-reviewed publications. He has done his fellowship training in endoscopic approaches to sinonasal and skull-based tumors from Germany. He has done his training in minimally invasive endoscopic surgeries of the skull base from USA. He has been mentor to many budding surgeons like me. Thank you, sir, for taking out time from your busy schedule. I can imagine how difficult it would have been for the FHNO president on the World Cancer Day. Thank you, sir, and over to you, sir.
Thank you, Swapnil. At the outset, I'd like to thank the Indian Dental Association Nagpur branch for this invitation to speak on World Cancer Day. I'd like to share my screen. So the objective of this meeting was to highlight the focus, bring the focus onto oral cancer and what is the current status and how we can go about closing the care gap. This is the motto and theme of the World Cancer Day this year. So let's begin with some key cancer facts. 10 million people die from cancer each year. At least 1/3 of common cancers are preventable. Cancer, as we know, is the second leading cause of death worldwide. 70% of cancer deaths occur in low to middle income countries. Millions of lives could be saved each year by implementing resource appropriate strategies for prevention, early detection, and treatment. And it is a humongous cost to the entire planet with this burden of cancer treatment. World Cancer Day is celebrated on 4th February with a singular initiative to unite the world in the fight against the global cancer epidemic. Its aim is to prevent the millions of deaths annually by raising awareness of cancer, by educating people about cancer, and by engaging governments and individuals globally to take action against the disease. Oral cancer is something that we are all aware of, and it is the ultimate paradox. It is so visible, it can be examined easily, and it can be seen by everybody who's even a healthcare worker. But to our discomfiture, we are seeing advanced cancers, stage 3 and 4, in majority of our cases. And this is a very sad situation. In India, more than 2 lakh new head and neck cancers occur per year, and almost 30% of these will be oral cancers. And what is surprising is 50% will die of cancer in the first year. When you look at the statistics of world cancer, India ranks amongst the highest regions where cancer occurs. The updated Globocan 2020 shows that the global cancer rate has increased to 19.3 million cases, and 10 million cancers will die each year. So in India, when you look at all the cancers, the lip oral cavity ranks amongst the top 5 cancers in the body, and they occur in both male as well as in females. So what is it that we need to tackle in India? We have a large population, we have humongous illiteracy, we have a large rural population with poor access to healthcare resources, and there are inequalities in healthcare on all grounds in all cities. And the average delay of diagnosis is 6 months. And that is the reason we are seeing our patients come to us in advanced stages. It is very easy for us to actually look at these early on, dysplastic lesions, before they undergo a genomic instability to undergo a transformation to cancer. So we know all this. We know that if we catch them early, we can actually prevent the progression. So we need to look at these patients when they have potentially malignant disorders rather than when they transform into cancer. Excuse me. So when we look at the high risk individual, we know that they are easily accessible. The low cost technology is used to actually diagnose these, and we can intervene when before there is a progression of disease. And we can actually give definitive treatment if detected. So screening is something that we know is feasible, and Dr. Sharmila Pimple will talk to us about these. We know that oral cancer was amongst the first screening programs which was randomized and published from Kerala. And in these, we know that it was effective in the high risk population. Now, in the World Cancer Day, the theme is close the care gap. So we need to close this gap between situations where everything is available and amongst the destitute where there are no opportunities for any healthcare. So what I would like to advise the lay people who are hearing us is that you can do many things to prevent cancer. You need to quit smoking and stay away from other people's smoke, because tobacco causes cancer across the body and not just the lung. We need to keep a healthy weight and exercise regularly, because overweight and obesity are linked with at least 13 kinds of cancer.
I request
There's some
everyone
disturbance.
to kindly mute themselves.
And whenever there's a possibility of a screening test, we need to do it. Screening may find breast, cervical, and colorectal cancers early. The parents should be advised to get the kids vaccinated against HPV at age 11 or 12, because HPV cancers are on the rise, and HPV vaccine can prevent many cancers later in life. We need to protect our children and their skin from sun, because the UV rays from sun and tanning beds can cause skin cancer. And we need to see that our children eat well and stay active. The healthy weight lowers risk for cancer and other health problems. Now, how do we go about ensuring that we have health equity? We need to educate the public about cancer prevention. We need to equip our doctors and nurses with skills and knowledge of cancer care. We have so much of health infrastructure, but we need to strengthen the primary healthcare delivery in communities. We need to advocate for policy changes. Those of us who are having the ear of people in the governing bodies, we need to advocate for policy changes to ban practices which negatively affect people's health. We need to increase the resources dedicated to cancer research, and we need to implement India-specific cancer prevention and control programs. Thank you for a patient listen. Swapnil?
Thank you, sir, for enlightening us with the ongoing cancer situation in India. Sir, we have few questions, but from my side only. Sir, because of this COVID situation, we have already understood the importance of telemedicine. Can this telemedicine help us in reaching the remote areas, sir, for cancer?
So we had, because of COVID situation, as you rightly mentioned, there was a flurry of activities wherein teleconsultations began way back in 2020. And the patients who could not travel large distances were able to communicate with their doctors. What is more important is that there was a touch with the medical fraternity, which actually helped the patients. But when you go to look at the realities, you need to actually examine, you need to biopsy the
Yes.
patients. So we need to actually have centers in the remote areas wherein they can have small outlets where the facilities for proper visualization for biopsy are available, which can be done by a paramedic technicians. So if you have outreach areas where you can actually visualize a lesion better. Now in oral cavity, you need nothing but a good light and magnified view. But unfortunately, the cameras which are there on the mobile devices are not adequate to give us that kind of view. So if we were to implement telemedicine, teleconsultation, the least that we need is outposts in the far reaches where they would have a good light source, and using the same camera with the light source, you'll be able to visualize the lesions better. And of course, as we have seen, there is a chart available which was popularized by the Kerala oral cancer study, wherein you detail out what is suspicious and what is not. And so if your paramedic technician is there at the site when you're doing the teleconsult, it'll be very easy to actually look at these populations which are high risk because of the usage of tobacco and betel nut.
Yes, sir, definitely. Though that is the path ahead, sir. We welcome the other questions. If you have, you can have questions now. Okay, thank you, sir. Thank you for your sharing us with your knowledge, sir. Thank you very much.
Thank you.
Now I'll like to welcome Dr. Sharmila ma'am. She is the professor in the Department of Preventive Oncology at Tata Memorial, Mumbai. She has done her MD in Preventive and Social Medicine. She holds diploma in Cancer Control and Prevention. She holds a diploma in Molecular Prevention. She holds fellowship in Public Health Leadership and Implementation Program. She holds fellowship in Cancer Epidemiology, and she is the head of WHO Collaborating Center for Cancer Prevention, Control, Screening, and Early Detection in India. And she has been a primary investigator for multiple research projects. Ma'am, we welcome you for our talk, and thank you for taking out some time for this talk, ma'am. Over to you, ma'am.
Thank you so much, Swapnil, and the Indian Dental Association Nagpur branch for this invitation. So I would like to share the screen. I think you'll have to allow me to share the screen.
We have allowed you, ma'am.
Okay, thank you. So at the outset, I would like to just declare that, I was not aware that even the general population is part of this presentation. So I'm sorry, I apologize if it sounds too technical because it was planned to be addressed towards the budding dental graduates and postgraduates. So excuse me for that. And I begin my topic was screening for oral cavity cancers, past, present, and future. So I'll just quickly take you through the presentation. I thank Dr. Prathamesh Pai for introducing the importance of the topic and the public health importance of the same. So I need not emphasize upon it again. So as we know, like, I mean, the risk factors for oral neoplasia, like, I mean, they are now kind of more comprehensive in terms of not only just tobacco, but alcohol, the significance of the areca nut within the Indian context and the Southeast Asian countries, the synergistic factors for tobacco, alcohol, dietary factors are playing an important role. Oral hygiene, for that matter, is playing an substantial role in terms of the inflammatory environment and the oral microbiome, for that matter, which is contributing towards, which could be contributing towards the initiation of the oral precancerous lesions. And of course, the factor of human papilloma virus, okay, which is gaining significance in the Western world, but less so within the context of our Indian subcontinent and some other low socioeconomic countries. So there is also some more recent role of Candida and the HPV, which has been documented, and the epidemiological evidence from the US population, which indicates a strong association of HPV with that of the oropharyngeal cancers. So again, just trying to portray the incidence of like cancer, and this is just trying to show you the various depicting various countries and where we stand in terms of our country. Though it sounds, I mean, it looks less, but like, I mean, the consumption of smokeless tobacco and related products, including smoking, is on the rise. And we have to be cognizant of the fact that we need to take action very early. As Dr. Pai has emphasized, I mean, there is ample evidence as to why we should be screening. I mean, the public health importance of this particular oral disease, okay, as oral cancers which can be prevented and detected earlier. And it fits into the principles of the screening as to why we should be screening. Of course, when we screen, there are benefits and harms which we have to weigh again in terms of, you know, the plethora of choices that we have. We want to reduce the severity, including less invasive treatment, inducing which can reduce the incidence and reduce the deaths and, I mean, mortality. But at the same time, when we are talking about introducing screening for a particular disease, we got to be cognizant of the facts of it being false negatives, false positives, and overdiagnosis. So we will weigh this against the backdrop of the oral cancer screening modalities which are available. So goes without saying that oral visual inspection is the, I mean, which Dr. Prathamesh also emphasized upon. This is the only cancer which has given you, I mean, oral visual inspection as a screening tool, which has provided us with the evidence through randomized controlled trial, which was conducted in our own country, and the results of which are available till the 4th round of screening. And we have some aspects of adjunctive devices and what is the evidence for the same. So as we can understand, oral visual inspection is, I mean, it's a very simple tool, very simple technique. We can train just any healthcare worker for that matter. And in our own studies, we have just trained 4th or 5th grade individuals, both male as well as female, who could be trained in oral visual inspection. So it satisfies, as a disease, oral cancer, it satisfies the criteria for a sustainable, for a suitable disease for screening. And visual examination is the most common method with good source of light, which can be used to detect visible lesions. Now, there is good evidence in terms of evaluating oral cancer screening programs that has used oral visual examination as a screening tool, and with good amount of sensitivity and specificity at some places with good positive predictive values also. But all depends upon the kind of training, the quality assurance the program brings in when we are undertaking these particular tests. So does screening for oral cancer reduce morbidity or mortality? So the randomized controlled trials represents the highest level of evidence for assessing the efficacy of an intervention. So when we look, so the only randomized controlled trial for oral cancer screening was conducted in India. But obviously, because India and most Southeast Asian countries have the highest incidence of oral cancer for that matter. And this was one RCT for which we have some 14 to 15 years of follow-up, which was undertaken in Kerala. And the randomized controlled trial was obviously planned with the intervention of oral cancer screening being given to the intervention arm, and we had a control group wherein no such intervention was given. So they reported a statistically significant reduction in the male mortality among the high risk groups, okay, but did not show any statistically significant reduction in overall mortality rates. So the study investigators had also stratified undertaken a subgroup analysis for which they were not powered, okay, and wherein this subgroup was comprising of tobacco or alcohol users, because this entire trial was on general population. And within the context of the general population, they identified this particular subgroup of high-risk groups which were consuming tobacco and alcohol. And there they found 24% reduction in mortality, which was reported amongst this particular group. So the study conclusions was there is evidence that visual examination as part of a population-based cancer screening program can reduce the mortality rate for oral cancers in high-risk individual. And in addition, there was also a stage shift in terms of the early stage detection for the cancers and improvement in the survival rates across the population as a whole. Now, further to that, there was a subsequent fourth round of screening, which was completed in 2009, and this was reported in 2013. Now, after the fourth round, okay, which is a significant contribution by this particular randomized controlled trial, because it is providing us the fourth round of screening results, okay, and herein there was overall significant improvement in the survival rates, say 5 to 10 year survival rates in early detection, but there was no significant improvement in the mortality rates in the overall mortality figures. But for those individuals who participated in all 4 cycles of screening, so only around 20,000 persons completed 4 rounds of screening, which is around 20% of the eligible population. So herein the overall reduction in mortality was 79% in the intervention arm, and reduction of 81% in the high risk group for the people who participated in the 4 cycles of screening. So this is some good addition. So this is some good evidence, added evidence after the 4th round of screening. So what's the significance of this so-called randomized control trial, which was conducted in India? So it has provided us, good level of evidence, okay, which is after the 3 rounds of screening and the 4th round of screening, wherein the report highlights life-saving benefits of the program to high-risk subjects detected with oral cancers or the oral potentially pre-malignant diseases, and which far outweighed any potential harm to those subjects for that matter. So any screening tool or trial has its own strengths and weaknesses, and same goes for oral cancer screening also. So conventional techniques of visual examination for oral lesion these conventional techniques can reduce mortality when exposed to risk factors. So, but there are several disadvantages or that limit the clinical utility of this particular technique, and there is need for screening aids that efficiently differentiate between a benign versus that of a malignant lesion. So we are all very well aware that to a particular primary healthcare worker who has been trained to detect precancerous lesions, or herein, in terms of the qualitative evidence or the qualitative thing that we are doing, it's a subjective interpretation of a lesion or a no lesion. But whether that lesion, so-called, in terms of the referral criteria, whether it would be benign or malignant has to be further investigated. So oral visual inspection, though we can bring in the pool of potentially malignant, clinically potentially malignant disease, but I mean, whether it is benign or I mean, it has precancerous potential, that needs identification and differentiation. And herein it brings in the weaknesses in terms of overdiagnosis, weaknesses in terms of what do we do with this overload of so-called screen positive population that we have diagnosed, and what do we do with them, because you got to link it with appropriate diagnostics as methodology or the diagnostics, okay, which could be available. And then depending upon the robustness of the health infrastructure for that region or that particular country, whether you'll be able to afford that particular appropriate diagnostic confirmation in terms of it being malignant or not malignant, lot depends upon that, wherein we are planning for population-based cancer screening program. So we are all conversant with the length time biases and lead time biases, okay? So we understand that the more aggressive cancers would be detected, okay, much before we can even start with the screening intervention, and the less aggressive or indolent cancers, or the ones which are not really going to progress, are likely to be detected within the screening round. Same goes with the lead time bias and overdiagnosis. So we all understand that the aggressive cancers are going to be like, I mean, it's a matter of time, okay, wherein non-progressive oral pre-malignant diseases, okay, in terms of the overdiagnosis, okay, they are going to have a longer length. Indolent cancers are going to have a longer length, whereas the aggressive cancers will be showing the lesser length because of the aggressive nature of the cancer for that matter. So in terms of the evidence or weighing this particular evidence of the randomized controlled trial, which is the only randomized controlled trial globally available as of now, which is providing the needed evidence. So, but what happens, like, I mean, how do you weigh this particular evidence? So Cochrane review have found a number of methodological weaknesses in this particular trial. So these limitations were in terms of the imbalance in the baseline risk factors between the intervention group and the control arm. There were small number of clusters, okay, because I mean, one cluster size was much bigger. At times it helps to have a larger number of clusters with smaller numbers within. Then there was inadequate accounting for clustering in the analysis. There was no compliance with follow-up, as we saw that the 4th round of screening was for only 20% of the population who participated in the 4th round of screening. And then the possible lead time and length time biases that can feature into the interpretation and the analysis that was offered, and the reporting outcomes cumulatively rather than for each round of screening. They had reported cumulative outcomes rather than after each round of screening, which is at times difficult. But I mean, these were the flaws or the methodological weaknesses that were cited by the Cochrane review. So, but with whatever methodological weaknesses, the Kerala study does demonstrate the potential of allied health professionals undertaking oral cancer screening, okay, and we can have a population-based screening program as a very low cost effective tool which can be implemented without much cost, okay. Now we have to weigh the benefits and harms of screening, and that's an essential component of any program. So, like, I mean, if you look at the RCT which was conducted in Kerala, the sensitivity reported was relatively low. In addition, there were false positives. I mean, the false positives can have, as we understand, unnecessary investigations and psychological consequences or increasing anxiety. If we tell them that, oh, you were detected with something, but I mean, we are not able to take them through in terms of the actual diagnostic verification if it is not there. And recent studies have highlighted the need to train general dental practitioners, okay, and the need for standardized criteria to avoid both this over referrals or over diagnosis also for that matter. So the conclusions of the Cochrane were that the RCT evidence for oral visual inspection, which was provided by the randomized control trial from Kerala, there is evidence that visual examination as part of a population-based screening program reduces the mortality rate of oral cancers in high-risk individuals. So like, I mean, we can look at implementation of population-based screening, but it could be more beneficial if you involve the high-risk individual rather than implementing it for the general population. There was stage shift and improvement in survival rate across the population as a whole. But however, the evidence is limited to one single study, okay, which had some methodological weaknesses and high risk of bias, etc. So, and in terms of the adjunctive technologies, they said there was no evidence to support the use of adjunctive technologies like toluidine blue or other fluorescence imaging screening tools to reduce oral cancer mortality. So as we can see, oral visual inspection, if it is implemented, depending upon the quality of training and depending upon the quality assured program which is implemented, the sensitivities can differ from 18 to 90, 95. Specificities can range between 50 to 99%. Positive predictive values for that matter can range. So overall, because of the subjective nature of an oral visual inspection, which is a subjective screening test, okay, the variations in terms of the test characteristics are predictable. So herein we go, and we have enough evaluations for the conventional oral examinations in terms of the sensitivity and specificity characteristics. The cost effectiveness analysis was also undertaken, and it seems to be quite cost effective if you train healthcare workers which can undertake population-based screening programs, and there is incremental cost per life year saved also, benefit in those terms also. So overall recommendation is that, like, I mean, visual inspection as part of the population-based screening program can reduce the mortality rate of oral cancers in high-risk individual. There is stage shift, there is improvement in survival rates, okay, and it could be something which could be undertaken by low middle income countries. So considering that, like, I mean, the evidence as of now was by a single RCT from Kerala, and this was implemented for the general population. Tata Memorial Center has ventured onto a randomized control trial to look at the effect of screening with oral visual examination on oral cancer mortality among the high-risk group. Now, this is the one randomized control trial which was undertaken with the intent of looking at reduction in cancer, oral cancer screening mortality if we undertake this particular screening among the high-risk individuals. And these high-risk individuals were tobacco users and alcohol users. This study is planned for 2 rounds of screening at 3 years interval. We are training the healthcare workers who will examine the oral cavity of the people with high-risk factors. The study will be enrolling 55,000 subjects in the intervention arm and another 55,000 in the control arm. So the study is ongoing. We have 7 clusters of subjects with 7,500 subjects per cluster, and the trial is registered with the clinical trial registry program, and the primary objectives are to assess the effect of screening using visual inspection by trained healthcare workers on oral cancer related mortality. We will also look at to assess the improvement in survival after a diagnosis of oral cancer, and also to identify possible etiological factors in a high-risk population in Ratnagiri districts of Maharashtra, where the prevalence of smokeless tobacco use and areca nut chewing is much more higher. So this is the overall plan. This is the status of the study as of now. We are still, I mean, we are now into the surveillance round of the study, and the results would be out. Now, coming to some other modalities in terms of, there is much talk about mouth self-examination and whether that can contribute overall. So, but the evidence is very limited, and the evidence, I mean, in terms of the trials, there is no level, I mean, the level of evidence is much fair. I mean, not so good in terms of utilizing mouth self-examination. The way we talk about breast self-examination, same goes for mouth self-examination in terms of the compliances and how do you train the population or individuals in examining, and whether that can contribute, though it can be practiced as a discipline in terms of we can advocate it to be practiced during the health education or cancer awareness session, but this is not some modality which we can use for the population screening themselves. I mean, cannot be advocated. So in terms of other modalities, autofluorescence, chemiluminescent elimination, toluidine blue staining, okay, the Cochrane review is out in terms of there's no evidence to support the use of adjunctive technologies for that matter. And currently routine screening for oral cancer with oral visual inspection by trained healthcare workers among high risk individuals who are consuming tobacco or alcohol can be recommended for countries like India in areas or in areas or regions with a high burden of oral cancer. Another important aspect is, which is popping up again and again is the evaluation because of the component of the human papilloma virus and its relation to the oral cancers for that matter. So HPV has been accepted as a causative agent for a subset of head and neck squamous cell carcinomas, particularly of the tonsils and the base of the tongue. So now, although this relation is well known, it is still not clear that whether HPV could be the responsible agent in pre-malignant oral lesions and dysplasias. So, as of now, in terms of the epidemiology, risk factors, the carcinogenesis, biomarkers, and the clinical implications, there is a lot which has come up in the literatures, okay, for the increasing incidence of HPV-related oropharyngeal cancers, most cases being attributable towards HPV-16, to the clinical implications in terms of it being a known clinical entity with potential for the and the effect of the prophylactic HPV vaccination on the same thing. So with regards to HPV, the screening for HPV positive or oropharyngeal cancers, now given the global increases in the HPV driven oropharyngeal cancers, in which the conventional oral examination, our oral cancer screening or conventional oral examination is limited to the oral cavity and limits the interpretation for the tonsillar fossas. So in a preliminary study, the oral rinses to detect HPV-16 DNA and mRNA in positive oropharyngeal cancer patients was demonstrated, but it was demonstrated to have moderate to poor sensitivity. So, the oral rinses for detecting HPV related aspects for oropharyngeal cancers could be still very, very doubtful, and we do not have much robust evidence for screening of HPV positive oropharyngeal cancers. I would like to comment one thing, that the evidence for HPV related oral cavity cancers is much low in Indian context, and the study, as far as Indian studies goes, we are more on tobacco related HPV cancers rather than smokeless tobacco related oral cavity cancers rather than HPV. We haven't found enough evidence in the Indian context for HPV related cancers, which are more among the, which has good evidence from the literature from the Western side, but from the Indian context, there is limited evidence for the role of HPV in our oral cancer context. Now, there are some evolving technologies in terms of e-health, artificial intelligence, and mobile technology for screening. So we can definitely use this mobile technology wherein the primary healthcare workers, okay, can undertake this and have the images which can be interpreted by the experts from the remotest possible locations. Like the healthcare workers could be located in some areas wherein there is no immediate access to the expert opinion, but the mobile pictures can be, or the mobile oral images can be transported to the remote experts, and you can have an opinion. But these studies are, though promising, it needs evaluation in the real world settings as to how artificial intelligence and e-health or mobile technologies can really help into screening. And there have been some studies wherein they have taken it on as a small demonstration project models, but we need to have good evidence in terms of some kind of randomized controlled trials, okay, which can say that this can really help in remote areas. So the conclusion remains that oral cavity is an easily accessible site for screening. It can be undertaken by trained healthcare workers, which has been already recommended in the operational guidelines of the Government of India, okay, for the common cancer screening under the non-communicable diseases program. And targeted clinical examination of high-risk individuals may be more effective than the mass screening in population-based screening. Rather than screening the general population, we can have targeted approach towards a high-risk individual, and probably that can help. So I'm sorry if I've taken longer time than which was provided for me, and thank you for the opportunity to present.
Thank you, ma'am, for this informative session. I will like to invite the questions now. There is one question, ma'am. There is nowadays a boom of well scope. So how good is that, ma'am?
Well, we had investigated this well scope technology a decade earlier, 10 years back, and we did not find much difference, or rather no difference, between well scope guided detection versus that of our healthcare workers detecting the oral pre-malignant lesions. In fact, the study gave us reverse this thing, wherein the sensitivity of our healthcare workers who were trained sufficiently in diagnosing oral pre-malignant lesion was much more than the well scope. So as a technology, we had rejected this, and because there was a negative outcome, okay, the company refused to publish these results in the review journal. So the Cochrane review is there out, okay, to say that there is not much evidence, okay, in adjunct technologies like that, and we have reviewed it a decade earlier.
Okay, ma'am. Next is how to upgrade a clinic, a dental clinic per se, with minimum expenses for oral cancer screening. Do we need to do something extra, or just physical examination will be suffice?
Well, because it's a dental clinic, and we say we can understand a dental clinic from the perspective of a secondary level care, okay, a secondary level care. So besides primary screening, which the dentist would be practicing anyway and could be equipped with, what is important here is whether they can provide some kind of a diagnostic aid to the people who are approaching them, in terms of, this is a different topic by itself in terms of what can help, whether oral cytology can help, whether oral brush biopsies can help, or whether we need to take punch biopsies, or whether we can take excision biopsies, okay. It's debatable, but providing some kind of a diagnostic aid by a dental clinic, okay, with their whatever resources they have, and linking it to the nearest pathological laboratory would be something which can be expected. And we can say that from the cervical cancer screening context, okay, we had trained our nurses also to provide cryotherapy. So in that context, whether a dental surgeon would be equipped with the aspect of doing some kind of excision, wider excisions, which can be practiced at the dental clinic, if possible, can help with diagnostic as well as some kind of a therapeutic measure which can be adopted. And I mean, these are the qualities these are the things which need to be enhanced at a dental clinic. That's my personal opinion.
Okay. Thank you, ma'am. Thank
If
you.
I may add, Swapnil, to what Sharmila mentioned, it is very important that we are not looking at a biopsy only. We are looking at surveillance. So even if the dental surgeon feels that this is looking suspicious and they do not have the wherewithal to remove it, it would be ideal that they identify a group of people in their locality or in a metro city where the patient can be referred. So I would, not do a wide excision in the clinic, because that will compromise on margins and make life more difficult for the treating physician. So if you really suspect it, we should have a chain of a follow-up clinics, wherein if you detect it in the rural area or detect it in a second or third tier city, it may be better to refer it back to another surgeon who will be actually taking a biopsy and treating it definitively. So I feel that this kind of a system should be developed. The time has come wherein we need to have the levels of care developed and defined, and the Indian Dental Association should take this up in a major way. So the people who are doing general dentistry should be able to at least diagnose that this is looking suspicious, and then pass it on to the maxillofacial surgeons who will actually do the definitive care. If everybody messes up, then it will be like a delay in diagnosis as well as a improper treatment given to the patient.
Yeah, I completely endorse what Dr. Prathamesh said. And, just adding to that, what is the most important thing Dr. Pai pointed out was referral linkages, actually. Okay.
Yeah.
So the dentist clinic can act as, the referral linkages, and plus follow up also, because I mean, he's somebody like a primary physician established in the community, and wherein you can definitely have good surveillance and follow up with these patients who are so-called oral screen positive. Not only the follow-up surveillance, but subsequent referral linkages and establishing the diagnosis could be the right way to go. Yeah, thank you, Dr. Prathamesh.
Thank you, ma'am, and thank you, sir, for your valuable time.
Dr. Swapnil,
Yes,
this is
ma'am.
Dr. Huri. Yes, ma'am and sir, I would like to ask one question to you. Like being a dental professionals, that when we are equipped with the biopsy front and all, if we are able to perform biopsy, or we call a maxillofacial surgeon, whatever, at our clinic for the biopsy part, then after that, whom should we consult, whether histopathologist or a oral pathologist are more equipped or more capable of giving us a diagnosis for the same? Whom should we go? Should we go to the histopathologist or to the oral pathologist?
Sharmila, if I may take that question.
Yeah.
It doesn't depend on the oral pathologist or a histopathologist. Like we are not debating any longer whether head and neck surgery should be done by the maxillofacial surgeon, ENT surgeon, or oncosurgeon. It should be done by a trained surgeon. So now if your oral pathologist is trained to diagnose cancer, and he will not miss a cancer, then you should be sending to oral pathologist. Now, I may put it in another way. If you don't train your oral pathologist, they will never be able to diagnose it. So if you have a good oral pathologist in your group who is going to take this up, I think they should be given the samples and asked to work on it and hone their skills, so that in future they'll be able to diagnose these better. So and if there is like the IDA may develop a whole referral link, as Dr. Pimple put it. If you have the whole link, doesn't mean only treating physicians. It is a pathologist, it is the radiologist, all together form that entire group that will treat the oral cancers better. So it is very important that we train the entire chain, the pathologist, the radiologist, the surgeon.
Thank you, sir. Thank you, ma'am.
So we should have some short-term certificate courses or short-term teaching programs for diagnosis and these linkages, sir.
Absolutely.
Thank you, sir. Thank you. So we couldn't arrange a physical cancer survival meet. So we have a few messages from the patients who have survived. We have selected few messages. Few patients which got cured from a very early diseases, and few patients who have advanced disease. Now this patient who had a buccal mucosa cancer, now post surgery he underwent a chemoradiation also. Now we'll listen to his message.
Swapnil, we cannot hear.
Yes,
Himanshu, sir, audio is not
audio
audible.
is not working.
The video is not audible?
No.
No, sir.
video is not audible, Himanshu.
Just a second.
एवढं दुर्लक्ष का
Is
केलं?
it now?
शाला आला होता तर असं छोटेसे दवाखान्यामध्ये जाऊन ते शालेय ट्यूब लावले होते.
तुम्हाला कळलं नाही की हे कॅन्सरचा छाला आहे म्हणून?
नाही, जेव्हा लॉकडाऊन मध्ये झाला होता तो, तर लॉकडाऊन मध्ये आपण घरच्या घरीच होतो, जेवण वगैरे होत होता बराबर.
अच्छा, आता तुमची कंडिशन कशी आहे? जेवण वगैरेला त्रास होतोय?
आता थोडा थोडा त्रास होते.
गिळायला त्रास होतोय?
तेज नाही खाऊ शकत. एकदम ओली भाजी राहिली ते खाऊ शकतो रसाची.
अच्छा, 4 लोकांमध्ये जाताना काही त्रास होतो असं वाटतंय आपल्याला की?
जाऊसाच ना वाटते कुठे लग्न शादी वादी मध्ये कुठंच कार्यक्रम मध्ये.
अच्छा, तुम्ही जे लोक ज्यांना छाला झालेला आहे किंवा जे तंबाखू खातात त्यांना काही सांगू इच्छिता?
हो, त्याला सिर्फ एवढं सांगू शकतो का तुम्ही तंबाखू वगैरे खाणं बंद करा का.
ठीक आहे. आणि छाला जर होणार तर काय करायचं?
त्याला ह्याला तर पहिले डॉक्टरले दाखवून देवायचे.
ठीक आहे, धन्यवाद.
हो.
It was a very advanced lesion.
Himanshu, please mute each and everyone.
Ma'am, I have muted everyone, ma'am. They actually open their unmute their self.
The whole point of putting this video here was to focus and highlight that after advanced lesions, even after surgery, even after the patient is disease free, the life is not easy. The patient is the quality of life what we can give in an advanced disease is very bad. So we can have a next video.
Okay.
दोस्तों, मेरा नाम रितेश त्रिवेदी है और मुझे गुटखा और खर्रा खाने से कैंसर हो गया था, जिसका इलाज डॉक्टर स्वप्निल अग्रवाल जी ने किया था और उनके द्वारा किया गया मेरा ऑपरेशन सक्सेस हो गया है। और मेरी आप लोगों से विनती है कि तंबाकू, गुटखा, खर्रा ये चीज़ों से दूर रहे ताकि आप लोगों को भी कभी कैंसर न हो। और अगर आप लोग अभी भी
This was a very early lesion. Patient had a small lip cancer which got treated. Now he's 2 years post surgery and he's doing absolutely fine. No social disagreement, no problem in going on for the social gatherings. Next video, please. Himanshu.
मेरा नाम मोहम्मद कयूम चौहान है। मैं मुल्ताई का रहने वाला हूँ। मेरा सेकंड बार ये ऑपरेशन हुआ जबान का और इसमें कोई प्रॉब्लम नहीं है। मुझे अच्छे से खाना पीना होता है और किसी भी व्यक्ति को ऐसी कोई तकलीफ हो जाए तो घबराने की बात नहीं है। ऑपरेशन से सब अच्छा हो जाता है। डॉक्टर स्वप्निल अग्रवाल जी ने मेरा ऑपरेशन किए हैं और बहुत अच्छा ऑपरेशन हुआ है और इसमें मुझे अब कोई भी दिक्कत नहीं है।
So this was a case in advanced lesion, but we could preserve a half of the tongue. So patient is speaking normally and having a normal diet also. Next, please.
Yes, one second.
मेरा नाम रसीला पटेल। 1 साल पहले मेरा लिप का ऑपरेशन हुआ था। अभी ठीक है। मैं सब कुछ खा पी सकती हूँ, कोई प्रॉब्लम नहीं, अच्छे से नींद भी आ जाती। बस आप लोगों को सभी जन को विनती है कि तुम लोग भी तुम्हारा कुछ मुंह में वगैरह कुछ ऐसा दिखे तो जल्दी ट्रीटमेंट करवाओ, सब ठीक हो जाता।
She was a non-tobacco chewer. She had developed a cancer of the right lateral border tongue, operated. Now she is doing fine. Next, please.
Yes, just
कॅन्सर हा रोगाचा प्रादुर्भाव दिसून आल्यामुळे मी नागपूर येथील डॉक्टर स्वप्नील अग्रवाल साहेबांकडे जाऊन तपासणी केली असता कॅन्सर हा रोग दिसून आल्याने ताबडतोब मी डॉक्टर स्वप्नील अग्रवाल साहेबांच्या सल्ल्यानुसार ऑपरेशन करून मी आज या डॉक्टरच्या सल्ल्यानुसार माझ्या तब्येतीमध्ये सुधारणा झाली असून मी नेहमीच औषधोपचार करीत असून यापूर्वी मला जेवण करणे किंवा बोलणे खूप कठीण जात होता, परंतु ऑपरेशनमुळे माझा जेवण चांगला जात असून बोलणं फिरणं मी माझ्या शेतीवाडीकडे सुद्धा चांगल्या प्रकारे लक्ष देत असल्याने माझ्या तब्येतीत सुधारणा झालेली आहे. म्हणून मी नागरिकांना हे विनंती करतो की यापुढे कोणीही वाईट व्यसनापासून दारू, गुटखा, सिगारेट ह्या अशा वाईट व्यसनापासून दूर राहावा व आपल्या तब्येतीची काळजी घ्यावा. जर असा काही आजार आढळल्यास ताबडतोब डॉक्टरचा.
He's a sarpanch from a remote village in Gadchiroli area. He himself have started organizing these diagnostic camps now, sir. Next video, please.
that was also basically.
Yeah, thank you. So patients who are getting motivated, they are now trying to spread the word, and they have themselves have started organizing the camps. They have started educating the people against tobacco and helping them getting the early diagnosis and treatment. So that is a good on the patient's behalf. So we can have the next next session, what we have planned now. Over to Rashmi.
Yes, sir. Thank you very much, sir, for such an informative and thought-provoking session. The whole session was really a splendid one. Now we are moving towards the end of the program. Now I request our moderator, Dr. Swapnil Agrawal, sir, to kindly present the certificate of appreciation to our honorable guest speakers, Dr. Prathamesh Pai, sir, and Dr. Pimpile, ma'am.
Thank you, sir, for taking out time, sir, from your busy schedule on this 4th February. It must have been a very difficult time. Thank you, sir.
Thank you, Swapnil, and thank you, IDA, for the invitation.
And thank you, Sharmila ma'am, for this very informative session and helping us upgrade our clinics also by this knowledge, and we'll be able to definitely do a screening at remote areas also. Thank you, ma'am. Thank you, ma'am. Thanks a lot.
Thank you, sir. Now I present certificate of appreciation to a moderator, sir, of today's event, Dr. Swapnil Agrawal, sir. Thank you so much, sir, for this wonderful session, and we will be looking forward for such more sessions in the future.
Thank you. Thank you. Thank you so much.
Thank you, sir. Now I invite our Secretary of IDA Nagpur branch, Dr. Poonam Hudia ma'am, for vote of thanks.
Thank you, Dr. Rashmi. They say that a feeling grateful and not expressing it is like wrapping a present and not giving it. I, Dr. Poonam Hudia, would like to propose vote of thanks on behalf of IDA Nagpur branch for the symposium on oral cancers and survival meet on occasion of World Cancer Day, 4th Feb. First of all, I would like to thank Dr. Prathamesh Pai for accepting our invite in such a short notice from Tata Memorial Hospital. We are highly grateful to you, sir, for sparing time for us and being with us. And we can understand in this such a busy schedule of yours, it must be very difficult for you to take out time for us. We are grateful to you for that purpose, sir. Thank you so much. I would also like to thank Dr. Sharmila Pimple, again from Tata Memorial Hospital, for enlightening us with the current scenario of diagnosis and treatment plan for cancer. Thank you so much, ma'am. I would also like to thank our own moderator, Dr. Swapnil Agrawal, consultant head and neck oncosurgeon, for accepting our invite as moderator of the event. We are fortunate, Dr. Swapnil, that you are with us as a member of IDA, and for arranging this survivors meet. It was a wonderful idea. Thank you so much, sir. I would like to express my gratitude to our dynamic president, Dr. Vaibhav Paramedic, and our own very sweet and perfect girl, our CDH convener, Dr. Rashmi Tonge, for carrying out this event so flawlessly. Thank you so much. This event would not have been possible without this attendance. I'm very thankful to the huge attendance who have witnessed our live link and who have joined us at the Zoom platform. We IDA Nagpur are very grateful to each one of them. Thank you so much. Last but not the least, a big thank you to IDA Nagpur branch members, Team IDA, for their constant support throughout, and with software Mr. Himanshu Subramaniam for the help. Thank you all once again. Thank you so much. This e-certificate will be mailed at your mail ID. Soon, I think it will take a day or two. As soon as we are done with this program, by evening we'll mail you the certificates, Dr. Swapnil, and I would like you to share your email ID with us.
Yes, ma'am.
Thank you so much.
Sure. Yeah,
Thank you very much.
Thank you,
everyone.
Bye, Sharmila. Bye.
Bye.
Thank you all. Thank you.
Thank you so much, everyone.
This meeting we can leave. Officially, the meeting is over, Rashmi. You can say that.
Yes, sir. Yes, ma'am.
Conclude the meeting.
Okay. Bye.